And we have ourselves seen our history has evolved. At the dawn of our independence, with a tilt towards a socialist mindset, we did think of a strong public sector as the vehicle for delivery of health services. We had the Bohr report as well, suggesting that community-based healthcare and primary healthcare are the things that need to be supported. But with gross underfinancing of the public sector, there was no way that particular aspiration could have ever been achieved. And by default, we have had a disorderly growth of the private sector, which has grown over the years in an unwieldy, unregulated manner, and not only has not delivered the care to the extent that is required, but has actually compounded the problems in many areas by escalating healthcare costs and by also introducing unethical practices in a number of areas. So now we have a mixed system in which we have a poorly resourced and underperforming public sector with a loose cannon in the form of a private sector, which needs again to be integrated in some meaningful way in the manner that Brazil has done. So, and of course, we did have our neoliberal economic policies as well in the 90s, which further diminished the attention being paid to or the resources allocated to the public sector, and that resulted further in the decline of the public sector over the years. Now, suddenly we have seen some revival of the public sector, at least through the National Rural Health Mission. And the fact that we do need to expend more of our resources on strengthening the public sector, especially at the level of primary health care, is a lately dawned realization, but at least it augurs well for moving towards a framework of universal health care. But that itself is not a sufficient guarantor of the acceptance of a framework or the potential successful implementation of such a framework. So let me just walk you through some of the thought processes that we have been having in relation to universal health care. Firstly, let me say that universal health care is not just about health financing. Obviously, there are several other elements to it. When we were told first to have this committee, I argued that financing is very important, central, and critical. But even if you had good financing mechanisms, if you did not have human resources, if you did not have the infrastructure, if you did not have a drugs and devices and vaccines policy, and if you did not have adequate regulatory systems in place, then mere financing mechanisms would fail to deliver universal health coverage. So the Planning Commission agreed and has brought in all of these elements into a unified terms of reference. Now, the social determinants of health, which are traditionally seen to be outside of the health sector's domain, like education, agriculture, water, sanitation, urban design, transport, food processing, all of them, even information systems and communication, all of which impact on health profoundly, but nevertheless are in the domain of other ministries and other sectors, also need to be considered very clearly. Again, Armando has pointed out that you cannot consider these separately. But clearly, while some of our recommendations will be directed towards those as well, our principal recommendations at this point in time would be looking at what can be done with the health system as it exists today, principally focusing on health services. And health finance becomes a very important element in this. Now, what do we find? There are 10 features of health financing and insurance which are important to note. Firstly, low levels of overall health spending. In 2005, India's total health expenditure as a percentage of GDP was 5%, less than the global average of 6%, but higher than the figure for neighboring countries such as Thailand, Sri Lanka, and China. Seems wonderful. But the picture, however, changes dramatically when the levels of per capita health expenditure are examined. When you look at per capita health expenditure, at total health expenditure, I'm not talking about public financing, at a total per capita health expenditure of about $100 per capita, India's health expenditure is only around half of that of Sri Lanka and 1/3 of that of China and Thailand. More interesting, the per capita government spending on health in India, which is $19, was around 25% of the level of Sri Lanka, which has $88, 10% of the level of China, which is $122, and less than 1/10 the level in Thailand. So when you look at per capita public financing of health, that's where we slide particularly downwards. And in 2004, 2005, the government expenditure, including external assistance, accounted for 22% of the total health spending. That means 78% is non-governmental spending. So we are really talking about high private out-of-pocket expenditures accounting for about 78% in 2004, 2005. Then there is a high burden of out-of-patient costs of treatment, which is very clear. High costs of medicines, that is, medicines account for 72% of the total private out-of-pocket expenditure. And there is rising costs of medical care. Between 1986 and 2004, the average real expenditure per hospitalization case increased threefold in government as well as private hospitals in both rural and urban areas. Now, there are wide interstate differentials in public spending. The average per capita public expenditure on health for India was about 268 in 2005. It varied from 93 rupees in Bihar to 287 rupees in Kerala. It's not surprising then that in Kerala, almost all births are conducted in medical facilities and 75% of the children are fully immunized, whereas only 31% of the births are institutionalized and 33% of the children are immunized in Bihar. Now this brings us to the question of health inequities. Again, one of the profound reasons why there should be moral outrage at the health inequities in India and why we should make a case for universal health coverage lies in the huge gaps that lie in the health indicators. Whatever we choose, we find across India, not only determined by geography in terms of interstate differences, but by rural-urban differences within each state, between social strata based on income, education, gender, and caste. So whatever the indicator you pitch into your analysis, you'll find that invariably all of them will show wide variation based upon, any health indicator will show wide variation based upon each of these social determinants. The life expectancy in Madhya Pradesh is 56 years as opposed to Kerala of 74 years, an 18-year difference in life expectancy within the same country, between different states, which is more than anywhere else in the world. A baby girl born in Madhya Pradesh is 6 times more likely to die before her first birthday than a baby girl born in Kerala. A pregnant woman in Tamil Nadu has 3 times less chance of dying in her childbirth than a pregnant woman in Chhattisgarh or Jharkhand, and we are living in the same country. So clearly, there is a case for universal health coverage which overcomes all of these glaring disparities in health equity. Kerala has roughly 1 public hospital bed per 1,000 population, whereas Bihar has 1 bed per 29,000 population. And we can go on. Negligible financial protection is the other feature.